Good evening and welcome to another episode of Viva Learning. I'm your host tonight, Isaac Towell. I'm honored to be back here again. It's our fifth webinar that we're doing here, which is fantastic. Tonight's webinar is going to be about extractions and how to simplify them in our practice. It's nice to see so many people attending here, getting so many from all around the world. That's really beautiful to see that Viva Learning has gotten such a tremendous reach and such amazing locations. Some good friends I see logged in, so everybody. Well, you see, I'd like to tell you a little bit about myself. I'm a general dentist practicing in New York. For those who don't know me, I practice a lot of surgery, so hopefully I'll be able to give you some tips. If you can see here in the top left corner, I'm a MINIC member, which is a Megagen International Network of Educators and Clinical Researchers. I know that's a mouthful, but it's basically a group of educators from the Megagen implant group, and we can share knowledge and some of the things that you'll see tonight, including some of the instruments, which have been sponsored by TBS Instruments and are run through commercially through Integrative Dental Systems, available through a lot of major companies such as Benko and Henry Schein and Patterson in the United States, which you'll see this evening. So I get to use a lot of these cool instruments that you'll see tonight. Also a board member of the Digital Dentistry Society in the top right corner of your screen, which is we just opened a USA branch. Please come and follow us on Facebook and see what we have to offer there. In addition, I am also a co-director of the group AIE, which is Advanced Implant Education, and we have live surgery courses all around the world, and I'll show you that a little bit later this evening. So let's dive right into some of our objectives. So, of course, when we're dealing with extractions, we have to be concerned about some medical considerations before we go in and deal with these types of cases. Our ergonomics of how you should be sitting and standing in these environments to facilitate ease of extraction. We'll discuss how to separate teeth from the soft tissues, how to dive into that PDL and get some luxation. We show you different instruments and how to prepare those instruments. And we'll discuss some requirements of an ideal extraction methodology, including some of the mechanical principles and the techniques that we'll use to do that. I'll jump into some biomaterials, what type of grafting products I like to use after we do some extractions, and as well as biologics like PRF, plate-rich fibrin, and lastly we'll end off on some post-operative instructions. So diving into the medical aspect of things, we always have to worry about the condition of our patient and make sure that they are able to have surgery being done. Many of our patients may present on aspirin, and it used to be recommended to stop aspirin 5 to 7 days beforehand. Nowadays, we've been actually hanging on a little bit longer and actually not stopping our patients off aspirin, especially if their INR is under control. So dealing with the patient's doctor is important. Those patients who are on warfarin, commonly known as Coumadin, are supposed to refrain 3 to 5 days before, but many of them cannot be taken off of their anticoagulant therapy because it's too high of a risk, in which case we often switch them to an injectable version of that, which is called Lovenox, just for the remainder of the day to try to have that under control. We can keep those patients on Lovenox for a few days before and a few days after, and then put them back on Coumadin. But mainly following in close proximity with our physician, the patient's physician, to figure those out. Pregnancy, patients who are lactating after pregnancy as well, we do have to be concerned about. A lot of times patients will present either pregnant or breastfeeding, and we are going to be using anesthetic on them. And it's often recommended not to use anesthetic with epinephrine. However, in surgery, we often need that epinephrine to be able to get some clotting factors. So that adrenaline helps us shut down some of those blood vessels. So when we do have to employ lidocaine, which with epinephrine, then we have to remember the pump and dump rule. If they're pregnant, we have to call the physician, speak to them about it. If they're lactating, then we can have them just do the one pump and dump of the breast milk for that patient. That typically, again, dealing with either the obstetrician or the patient's pediatrician or the child's pediatrician, and being in close proximity to them, dealing with them, having them in your consent. Bisphosphonates have been used now for many years, not just for females, but males as well. See a lot of males are on them for different things like prostate cancer, especially post-cancer. So we do have to worry about that. So things like that are going to be important. So they are going to be used, especially patients who are on IV bisphosphonates. Those can be a big problem, especially for dealing with things like BRON, which is radionecrosis of the jaw, bisphosphonate-related osteonecrosis of the jaw. So we have to be concerned about that to some extent. There is this 3-year, 3-month drug holiday rule that we employ. So if we're dealing with, let's say, putting implants into a patient, that 3-year, 3-month rule could be helpful. However, a lot of times we're not dealing with that. We're just dealing with a simple extraction. And so in a lot of these cases, patients who have been on IV bisphosphonates, highly recommend punting those cases or referring them out to an oral surgeon who's capable of handling that. A lot of times these cases can be helped with the use of things like platelet-rich fibrin to help to induce some vascularization to that area. But typically these patients will end up having what's similar to a dry socket, but you'll see the tissue just erode all around it and leave a ton of exposed bone, which is a real trouble patient to deal with. But if you look at some of these papers that have been written, you'll see that oral bisphosphonates are not really affect the implant success. So typically we don't truly worry about those in cases for extraction, but we do have to look out for those. So if you have a patient with IV bisphosphonates and you don't feel comfortable handling it, feel free to punt it out to local perio or surgeon in your area. So close communication with the patient's doctor is important. You know, whether it's through your staff or through you personally. I like to get on the phone and speak to the actual physician, not the nurse or anyone else. I like to speak to the physician and get consent with them, or I will print out a form and send it over to the actual physician for them to sign to get consent. But many times these patients will come in dire pain and emergency, and we have to be able to treat them. So sometimes a phone call we'll just have to do. So how do we stand? How do we orient ourselves when dealing with these types of extractions? So typically for maxillary teeth, we want to have this chair be a little bit further back. I typically will go a lot flatter than this image is showing to put them back so we can have direct access. But it should be at least 60 degrees to the plane of the floor. So we want to try to get them fairly level. You don't want to put them too far back because then too much blood rushes to their head and it could become more of an issue. But having your arm, the hand at elbow angle, basically if your hand and your elbow are both parallel to the floor, is very important. So you can get good rotational movement, which we'll talk about a little bit later. When dealing with lower teeth, obviously having them more upright is going to be more helpful. We'll be able to see a lot better that way. We're not going to have to go over the top of the patient or overhanded on the patient. We can kind of come at them more at a lower angle. Should be a lot more comfortable for us ergonomically, but also so that we can visually inspect the site very easily. Where do we stand? Many people like to sit. I personally like to stand, and often for being right-handed, I'll stand for the maxillary teeth and the anterior mandibular teeth into this front and right position. So it would be either in front here and on the right side of the patient. If you're left-handed, obviously it's going to be the reverse for that. For mandibular teeth, we're going to be, again, either in front or behind the patient. It can be either of the two, but to the right-hand side at this angle. So looking at it more in a 12 o'clock type of position. So getting that right inspection. The idea here is to be able to see what we're doing. We don't want to think blindly. We want to be able to observe what we're doing, see the movement of the tooth, because that's the key to success, watching how the tooth does come out and watching that it has some good rotational movement to it. The instrumentation is very important. We have to have all the different types of instruments, both for extracting teeth, whether it's curettes or peritones or hemostats, needle holders, scissors, all the necessary instruments, sterile suctioning materials, good retraction, like a Minnesota retractor, elevators. These are all important for the surgical extraction and important for surgery in general. And we need to have a sterile setup, not just for the equipment, but for ourselves. So either using sterile gloves, which can sometimes get expensive. And so if we're not doing a major implant surgery or a ton of extractions, or the patient is pretty healthy, then a lot of times we'll just use regular gloves and wipe them down with alcohol, which will then semi-sterilize the glove a little bit. But preferably, we'd like to use surgical gloves whenever possible, sterile surgical masks. Of course, eyewear protection is important. Over here, on this image here, you're not seeing the side sleeves that should be belonging here, but we wouldn't want to really get blood caught in our eyes, especially if the patient is a carrier of disease. And remember, you're not just protecting you from your patient, but you're protecting your patient from you. Sometimes we may be carrying something and not even know it yet. So it's important for us and our assistants to all be in a sterile type of environment, cover ourselves appropriately so that we can treat the patient with their best interests in mind. So autoclaving all our instruments, whether having packs, this is what I like to have in terms of packs. I've switched from this type of methodology over to the steri packs, but ideally we like to have things sterilized in cassettes. It makes things a lot easier. Instruments come out, they get washed, they go right back in, they go into a washing machine and then into an autoclave. That's the basic way that we do it in our office. Obviously, you can have the instruments held in steri packs individually, but that does take a lot more space up in the autoclave. So we like to use cassettes to make things a lot easier and faster. So the next step is to separate the tooth from the PDL itself. So the soft tissue is in the way, but we have to be able to wedge in a device to separate it so that we don't just take the tooth out and drag a lot of the tissue with it or tear a lot of the tissue. We want to try to do an atraumatic extraction, which I always laugh at the word atraumatic, because how is something atraumatic when you're basically ripping a tooth out of someone's head? Obviously, there's going to be some sort of trauma. So we want to minimize the amount of trauma that's being done to the patient. And the gingiva is obviously the most important thing that we want to try to save, the bone and the gingiva. So we don't want to just pull a tooth. That's the wrong term. We want to extract the tooth by separating it from the soft tissues and the hard alveolar tissues in the jaw. So using peritones to me is much better than using a periosteal elevator. They get in deeper, and you can get some really nice types of peritones. There's peritones that are straight. There are peritones that are angled. Straight ones are used predominantly for the anterior 6, and the curved are for those hard to reach areas in the posterior. And we'll have some examples on the next slide here of some of these. So you can have some thin or some thicker type of peritones, but they'll be angled. Some could be angled on a right angle and be turned for the mesial and distal, and others can be for the buccal lingual aspect, like here. You can see this flat end here would be for the buccal lingual or buccal palatal, and this one over here, which it would be kind of like a scraper O we would have for the mesial and distal. We want to wedge these in to try to get in between the area. And let's look at that in a little bit of a video here. You can see here where we have this peritome here. It's a straight peritome being used for a premolar because there's nothing else behind it, so we have some ease of reach. So let's start the video here. So you can see how we can wedge in with that straight peritome. And you can see these really nice crafted instruments from TBS, which has really nice serrations at the tip. Helps us dig in deep into that area, and we really want to separate it. And if we do this part well, then there's going to be very minimal stuff that we'll have to do after this. Often we can even skip elevators. If the tooth is semi-mobile, then usually this type of a tooth can be, because there's no molar behind it, it's been a little bit abused. If we separate this tissue appropriately, and often we can just use that. We don't actually have to go back in with forceps, with elevators. So let's discuss forceps. We all have them. We probably have hundreds of them in our drawer. If you're anything like me, I have probably about a good 300 different forceps in my drawer in my office, of which that I don't use anymore. I've switched completely to this newer style. This is an old style forceps, and this has a typical forceps will have a handle, all will, and it will have a beak. And this can change. It can change different shapes, different sizes. They can have serrations, no serrations, can have different angles. But this is the key. This is the hinge. And the hinge is how we're going to open and close the forceps. And I know I'm not telling you anything new, but I'm going to try to show you something a little bit different in a moment. So this hinge we have to actually hold the actual forceps open for us. So let's jump to this little testimonial that I did back about a year ago.
Over the years, I've had the opportunity and the luxury of seeing a lot of new products come out in the market. There was really nothing new in the surgical industry with anything to deliver teeth. It was standardized with our typical forceps that were really not comfortable. Obviously, with standard forceps, we have to use multiple fingers, and the grip is kind of hard. Along comes the Frings forceps, which was truly revolutionary product. No longer did I have to worry about holding the instrument with 3 fingers, just with 2 fingers and a light touch. Very comfortable and easy to use. I was very proud to help design some of the newer ones that are coming out onto the market. I think that this is a revolutionary product. For those of you who have pain in your hands and holding drills all day and using surgery, obviously the standard forceps is much less comfortable. It's more difficult to get a good angle on grabbing the teeth. With the Frings forceps, it couldn't be any simpler. Easy to use, comfortable in the hand, literally pain-free. I'm happy to endorse this, so much so that I've included it at all of my live surgery courses and all my hands-on courses. As you can see, we have many chairs, and they're all using the Frings forceps. So give it a try. You'll never look back. Thank you.
So as you can see from that video, and you can see from here, how we're holding this spring-loaded forceps. So I know that's a bit of an endorsement. I'm usually not so much pushing into advertising for a specific product, but I really have to tell you just how amazing these are and how comfortable they are in my hands, and how they've made extraction so much easier for me by having this light control, which you'll see throughout tonight's presentation, as I'm going to be using these exclusively to extract teeth, and which I do in my office. I dumped all my old forceps and just switched to these, and the key is in this spring-loaded area here, and it's very similar to what's feeling like holding a rongeur, but without that heavy feeling. It really is light, easy, and we have there's an internal mechanism in here. Instead of having an external hinge over here like a rongeur would have, this has an internal hinge right over there. So these types of this hinge will be right over here. I understand that maybe you might have had a little video error right there for a moment, so please guys notify me if we're back on. Okay, we're good now. Thanks, Todd. So you can see here, there's a little hinge in here, and the spring is based into this area here. A rongeur would have more of a U-shaped area here, helping it deliver its spring, but the spring mechanism is actually internal, which is really amazing how they were able to design this and do this. And very close with the inventor of this, Hasib. I know you're probably listening, but you can see what it looks like here. This is the design, and we've shaped many different of these. I'll show you some of the new ones in a moment, but there's the anterior ones that we use for the upper teeth, and there's extraction forceps. Typically these premolar extraction forceps that we hold one way for one side and one for the other. These can be used universally, so you can use either way based off of the shape, which is a nice feature, but typically you would use certain ones for the maxillary left molar forceps and maxillary right molar forceps, but the ones we have now are actually universal. So we have that aspect to it, which is a nice feature. The bayonets, which are the angled forceps here, you can see how they take a sharp angle, and this is to reach those hard to reach upper molar areas, first, second, or even wisdom tooth upper molars. Make it very, very easy to reach. In addition, we have the same type of design developed for a root tip. I'll show you a new one in just a moment, but these are really nice at grabbing root tips if you have that little extra area of separation that you can dive in and grab it. So very, very, very nice design. For the lower anterior region, I like to use regular nose beak forceps. We haven't developed the spring one for that yet, but I know that we're in the works on that. But this is typically what I like to use for the lower anterior section, and here's a little video of how to use the regular standard ones very simply after using peritomes. You can just simply pull straight forward and out. It's a nice feature of having these nose beak flies. You can do some rotational movements. All conical roots can have this type of rotational movement, so we can use it for that. For molars, especially for ones that have furcations, we like to use cow horns. No different with the Frings. We were able to develop these cow horns with a spring load inside of them, as you can see here. And this is really nice at going just in an up and down motion, being able to elevate the tooth through the forceps, by sneaking into that furcation and having the tooth jump out of a socket, obviously we need to have bifurcating roots for that. They can't be conical roots. Here's the new special edition forceps. You can see that we've developed 3 new forceps. Of course, mine are the best ones, right? You can see here this nice angle. This is more like a 151 type of forceps. It has these really sharp serrations here. My dear friend Neil Patel developed these for third molars, which you can see have a very sharp tip at the end. Really wonderful. I'll show you that in a moment. I've been using them for more than just third molars. They've been working out very nicely. And now for these really small roots, my mentor and my dear friend, Dr. Scott Gantz, co-director of Advanced Implant Education, developed these micro root forceps, which are absolutely fantastic. I'll show you some video on that as well, but they really grab these root tips very, very nicely, very easily. And with that spring action, you can really feel that you're actually holding on to the root, not slipping around in the mouth, not dropping forceps or instruments. Let's start talking about a little bit more of these requirements of what we want for a good ideal extraction. So obviously, a healthy patient would be primary. Secondly, we want to have good visual access of the surgical site. We want to be able to see what we're doing, and we want to have good access to it. So if a patient can't open properly, feel free to use a mouth prop. Obviously, if a patient has TMJ, find the right size of a mouth prop. TMD, find the right size of mouth prop so we don't lock their jaw or cause too much strain on their actual joint itself. We want an unobstructed pathway for that removal. If there's something blocking in the way, it's not going to be helpful. So something like a tongue or a cheek needs to be retracted. So a lot of times for surgery, we do need to have sometimes more than four-handed dentistry. We need to have a runner. Sometimes you'll need a person in there to be able to assist to go grab instruments for you so you don't have to come in and out of the operatory or run searching for instrumentation. So good retraction is important. And then the use of controlled force and or luxation to remove the tooth. And we'll go into that to more detail, but we need to be able to have that tooth mobile before we're going to go ahead and deliver it. So once we know that the tooth is somewhat has some movement to it, then we can go and deliver it with the forceps. So we'll use a PDL to separate it from that soft tissue. We'll use a peritome, to separate it from that soft tissue. We'll then go ahead and use an elevator on many situations to help luxate it a little, and then the removal or delivery of the actual tooth would be done with a forceps or even a hemostat, as you'll see in a little bit. So we want to be able to expand this bone. Bone is generally is pretty dense in the mandible and pretty soft in the maxilla, but by using this rotational principle, by being able to move grab the tooth and have some rotation either with an elevator or a forceps and having some rotational movement to it, we can expand that site and be able to deliver the tooth quite easily. And so that same patient that we separated with the peritome just a moment ago will now go in with the forceps and help expand that bony site. Let's play the video. And you can see here that spring action. You see how we're holding it very lightly. It has that little give, that little spring to it. And then some slight rotational movement. And this is really all you need, some rotational movement. And then start to expand the site. There's a conical root, so it should be pretty easy to get out. I'll show you some tougher ones in a little bit of a moment, but I think it really illustrates the point that we can deliver these teeth quite easily. So this expansion on molars especially can be a little bit more difficult, so we need to be able to consider how we're going to be able to do this expansion. We need to start initially with a buccolingual movement of that molar to try to expand it, and typically I'm talking about lower molars. Upper molars, I'm not a fan of taking out. I'll show you how I take them out. I'm not a fan of just grabbing them out unless they're really loose or they're conically shaped. If they have a trifurcation, I'll show you how I like to deal with that. But lower molars, if they're straight rooted, we can get some rotational force off of them. Initially buccolingual, and then give some coronal pull, basically, but not actually pulling the tooth. Remember, we're rotating and then trying to slide it out. I don't like to use the word pull. So we'll have some forces that will help us to deliver it going coronally out of the apex of the tooth, out of the apex of the socket, excuse me. So here's another example of the expansion of the socket. Here's new Patel forceps. which you can see in just a moment. And you can see, again, these are spring-loaded. There's Neil's signature. He has a very nice signature, much nicer than my signature. I had to write my signature about 30 times, but you can see this tooth has already been slightly elevated with an elevator, and then some slight rotational movement. And you can see as we do this, just keep rotating it buccal lingually, and then start in a circular motion, and then pulling coronally slightly. I hate to use the term pull, but just trying to rotate it and trying to deliver it out. We don't want to pull and then hit the upper teeth and break an upper tooth. As if we have a rule in our office, if we break it, we buy it. So we have a question about what about when the crown of the lower molar is like a shell. We'll show you. We're going to actually take off that tooth if we have that type of a molar. You'll see in a moment. So Marshall, if you can hang in there. No, Marshall, it doesn't make sense to try that rotation if it has that type of a shape. I would prefer, especially if they're divergent, that we section the tooth. But you can notice here how we're doing this rotational movement, and it takes a little bit of time. We're not in a rush. I purposely didn't edit this video out because I want you to see just about how long this should take. Even in the socket, we don't want to break the buccal wall. We want to preserve it for a future implant. And you can see now how it'll just come out very nicely without damaging the roots. Using those Patel forceps. So in this case, we had filled this with PRF. You can see that there's some PRF in the area. There was a bad infection. Patient was in pain. I didn't want to do a bone graft at the time of, so we just put some PRF in that area, and then we came back after using that PRF and placed an implant just a few months later. And you can see here's the actual extraction site. Look how nicely it's healed. Only about 2 months later, the implant went a little bit closer here. We didn't want to go into that area just yet, but we had come back and we had taken out 2 teeth and placed 2 implants here for a 3-unit bridge. So these mechanical principles for the elevator is great, but what about using them as a lever action? What about how using a forcep for a lever action? Let's talk about that a little bit. So typically what we want to do when we have an elevator is have the elevators, the shape side towards the tooth, facing towards the tooth. So you can see here how this is the shape here, and we'll have a rotational movement that pushes the tooth out, but not riding up against the tooth behind it. We don't want to now damage the tooth behind it and try to do a double extraction. We're trying to just take out this front one here. Now, when we are doing a double extraction, you can really angle it any way you want and use the 2 against each other a little bit. Or if there's no tooth behind it, you can angle the elevator in any way that you'd like. But if you want to try to avoid creating a mobility on a tooth posterior or anterior to that tooth that you're trying to take out, have the instrument facing the appropriate direction and then elevate it in that same rotation. So instead of turning it counterclockwise this way, we would go clockwise. Clockwise to try to pull this tooth out through its socket. So here's an example of using it as a lever action. Let's put play here. So you can see this crown has already been removed, and now you can see as we're just going to go ahead and elevate the tooth, luxate the tooth out into that rotation movement. Now once it's loose, now I can go ahead and I can take one of my forceps and simply go ahead and deliver it. Sometimes we can deliver it even with just a hemostat. I believe I have a video of that very shortly. So my hand was in the way there, but you can see, look at that fracture on that tooth here. If you notice that little fracture. So there you go. There's that little bit of fracture. So we can take it out, even a fractured tooth, we can take out quite nicely with using some luxation. So these mechanical principles of using a fulcrum and a lever are quite important, but sometimes we need to use this wedging type of action, not just using it as a fulcrum, but actually trying to wedge it in. And sometimes these elevators can be quite cumbersome at trying to go ahead and do that. So we have to employ different types of materials, such as luxatomes or proximators, and we've developed that through TBS these newer type of instruments, and we're proud to call them elevatomes, because basically what is a luxator? It's really just luxating a tooth. We want to elevate the tooth as well, not just to make it move, we want to elevate it out of the socket. So we want to use this wheel and axle principle. We'd also like to be able to use them and design them to be able to get some root tips. So these can be used to get root tips out, especially these 2 here can be used to get root tips out, which you'll see a little bit later on. So here we have a tooth, this tooth over here, number 30, or number 4, I want to practice this, so I think it's 4, 6, 4, 5, yeah, over here is for our international colleagues. This tooth is obviously severely decayed and needs to be removed. So let's take you through this video. So we'll have a crown on this tooth. We're not going to even bother with the crown. We want to cut it off, section it off. So we're going to take just a drill, just separate that in half and just remove the crown. And now we're going to take those two divergent roots, because they're root canal, then they're so subject to being brittle and breaking. We're going to section the roots in the buccolingual direction so that we can create two conical roots. So instead of having a furcated molar, we're going to have two roots divided on their own. In this case, I'm actually placing an implant at the same time. So you can see I actually use the drill, doing the drill through root technique. Then we use the periotomes to get in between these areas to separate that periodontal ligament. So valve in just a little bit there, separating all the tissues on the buccal, lingual, mesial, and distal, and then we'll employ these elevatomes and we'll provide elevation. So instead of using an elevator, I can use these little elevatomes that wedge in much nicer, and I can deliver it quite easily, and then you just pick up a hemostat at that point because the tooth is literally jumping outside of the socket. Same thing for the posterior. You can see we're using the angled ones, and sometimes we use a couple of different angled ones to find the right one that fits. So that first one didn't fit properly, so I went to the second one here, which is actually a little bit straighter, and then I'm going to the distal buccal of that, and you can see now the tooth is starting to get some movement out of it. So if I just stretch the bone just a little bit and relax it, I can do a nice, I wouldn't say atraumatic, but less traumatic type of a technique. I can take these two roots that are now sectioned, and I can go back in and now start to debride. So what am I going to debride with? Well, I'm going to use our curettes. We have these serrated curettes that work very nicely. I'll show you them a little bit later in another video. You can see we've already made an implant osteotomy there, and we're going to deliver an any-ridge implant that's going to be placed in there. And you can see the implant goes all the way down. And we'll get it right into the right position when I place my implants. As you can see from one of the other lectures that we've given, we try to place it subcrestal and closer to that mesial area where we can get it through a central fossa here. And we'll use some radio frequency analysis, which you can check out our lecture on that about implant stability quotient, which is also on the Viva Learning Center, and place our bone graft to fill these little gaps. You can see I've left my smart peg in there so I don't have bone graft falling into the actual implant site itself. So, sorry, Marshall, I see your question. No irrigation on placement. I irrigate during drilling. Usually I like to have a dry environment, place my implant, but there's nothing wrong with having some irrigation. And you can see I put some PRF on the healing cap and then just did a simple suture, simple X suture, and you can see that the implant took quite well. And you can see here is our final screw retained crown. You can see the nice soft tissue because we've kept the soft tissue and the bone. We haven't destroyed it upon extraction. So a lot of people tell me, oh, I'm having trouble with some of my implants. I'm losing some bone. No, you don't have to lose bone if you take it out nicely. Take care to that buccal plate, and good things will come back for you. So here is a trifurcated molar. We'll get to PRF in just a minute. Just hang on, guys. We have a trifurcated molar, and you can see this fracture in the area location in there. So what do we do with these types of teeth? I don't want to just pull because the whole tooth will just crumble. So what we're going to do is actually separate them into three roots. So we separate the lower into the two roots to make them two individually convoluted roots. Now we have trifurcated root. So we'll separate those into three. So we'll separate first from mesial distal, and then we'll separate the buccal roots individually. And once that's completed, that complete separation, you can see that we're down to the bone in all aspects there. And again, we can use our peritome to separate the soft tissues. Marshall, I despise the physics forceps. Someone's asking about the physics forceps. I find that they're great for breaking the buccal plate. We used to use them in the courses. So if you like to break the buccal plate, you can take a look at the physics forceps. They work wonders for that. You know, some nice GBR to do. So here we are now going ahead and using our elevatomes And you can see we're getting some nice rotational movement here. I'm glad you agree, Marshall. So you can see we're using the angled one to get that distal buccal root. And I'm going to elevate it just a little bit more. And you can see how these wedge in. We're using the wedge effect here. And again, using the wedge effect on the palatal root as well. And you can see it's starting to get some mobility. Now you can also go in between these roots, get in between them. Nothing wrong with that. So if you want to go in between, I think I do that in a moment. Here we're going for the mesial buccal root. We're getting some nice movement out of it. And trying to give you as much real time as I can. And again, here on the palate, you can see now all three roots are kind of moving together. You can tell when you're making these mesial distal buccal sectioning, like you're seeing here in just a moment ago, because we're going ahead and seeing the other two roots move. If they're not moving, and then as a fulcrum between each other, then that is an issue. So here we're using our Gans forceps now. Very nice thin forceps to be able to grab. So I use these for most of my roots to extract. And once I have it out, I might as well use it for all of them. So that's what we'll do. You can see roots come out very nicely, very easily. Nice, Adaf. Nice to see you too. We love the parietomes too. And here's the final rotational movement of that palatal root. And then we debride it again with the curettes. And we like to use these serrated curettes. And then this is what you'll see, which is a nice root. You have these three roots here, which are actually pretty good roots to use. So we can actually do something with those roots. So you can see this is a nice spot for an implant, but I believe we delayed the placement on this case. But we can actually take those roots. We can take them from this condition here. And using the dentin grinder, we can grind these up. But first, we got to get them nice and clean, get rid of all staining and no decay. No, and I don't really need too much enamel. I don't like enamel too much for this. And then we take these roots and we grind them up in this dentin grinder, and we can make actual bone graft, which is a really nice way to do that. So we have this dentin grinder, and we'll go ahead and spin the root. Spin it in the grinder. It's like kind of like a dentin blend, enamel dentin blender, cemented blender. So we do that for 3 seconds to grind it up, and we can sort it out. You can see we'll just push it around a little bit to get it through the holes. Play little games, try to get through some of the holes there. And once we're done with that, we then can remove it from the side cartridge, and you can see just how much bone 3 teeth can make that we just ground up in that video. But you can get really about a cc and a half to 2 cc's per tooth, and then we'll mix it with a cleanser. We've just revolutionized the cleansing process. It used to take 10 minutes. We're now taking it down to just 5 minutes using the new sodium hydroxide and saline. We pretty much, someone's asking what do we clean the tooth with? So we first clean the tooth just with a regular drill, a carbide drill to cut off all the tissue and all that. And then after that, go ahead and we can dry it out with just simple things like gauze. So once that's dried out and ready to use, we can now even introduce that with things like PRF and make it sticky. That was what we did here. We actually made sticky dentin bone, and we did place an implant in here. And now we'll talk a little bit about PRF and answer somebody's question about what is PRF. You can see the suture in here. So here was the implant in place. Actually, we'll talk about PRF in a minute. So what do we do when we have a curved root like this? Well, sometimes we can try to be a hero because we're running late and just try to take it out. And so let's try that. So we went ahead and we took our forceps because we saw some movement to it. And this is always a mistake. I always kick myself with this, but fortunately it worked out quite easily. But first we'll start with our peritomes and separate the root. And you can see the tooth has some mobility. So naturally I'm thinking, oh, this could be a quick, easy extraction. Let me get in and out here. And simply just go ahead and take our forceps and deliver it. So we're going to take our forceps. We did a slight amount of elevation first with an elevator for maybe a few seconds. We saw it was mobile, and we can see that we're getting some movement, so we did some rotational movement. We're using our patella forceps in this case, trying to do on that buccal lingual, and then going a little bit of coronal in our rotational movement. Someone's asking about what do I think about piezos for extraction. I love piezos for extraction. It works very, very nicely. We like that a lot. It feel free to use piezos if you have one as well. But setting up the piezo is a little bit time consuming, and there's extra tubing and all that. So I try to always take it out, and then if I break the tooth and I can't get the root out, then I go for a piezo. But typically these type of teeth I just section and try to elevate them out. But I'm a huge fan of piezo. I have a piezo surgery in my office, a few different units. I love the piezo surgery unit. And as we're doing this rotational movement, all of a sudden as I'm doing this, I hear a crack. Wonderful. Okay, distal root's good. Mesial root, not so good. So off to our curved LVtomes. So we want to find the right one to fit in the right situation. Very simply, since we had some good rotation here, and the root was movement, you can see it just popped right out, right onto the Minnesota. I love that when that comes out that easy. Then we go back in, and now we got to debride that site. So using our microcurettes, again, serrated microcurettes are wonderful at moving tissue. They really work nicely getting all that granulation tissue and infection out of that site. Sometimes we have to use something slightly more aggressive to try to get them out. So we can't always just use curettes. You can see this curette's doing a pretty good job. It's sometimes hard to reach some of these areas, and we don't want to destroy the bone doing that. So we try our best with our curettes as much as we can. And then after we have most of that out, we can even employ a special drills. This is a serrated drill from Meisinger, really nice drill, which we can use apically. And we rotate it around inside the socket and try to clean that out. Someone's asking, what do you do with a dull curette? I throw them out. You can send them back to the companies to resurface. I prefer serrated curettes. If they get dulled, a company like TBS will reshape them for you. So buy from reputable companies. The LVtomes and everything that you're seeing you saw are from the TBS, which is available through IDS, which is also available through Banco, Patterson, Henry Schein. Not Henry Schein, I'm sorry, Patterson, Banco, Atlanta Dental, Midwest Dental, a lot of that. So if you just go to search TBS Dental or instruments, and you'll find them. You can find them on the IDS or Integrative Dental System website. So this debridement is important. Getting these apical areas is very important to cleaning out the tissue. Here's an example of another tooth. Again, we're going to cut this crown off. Always remove the crowns. It just makes life just so much easier. Remove the crowns, section the teeth. Just make life easy for yourself. Turn a complicated extraction into a simple extraction by sectioning the tooth appropriately. You can see here we just cut the crown off and then sexual from the mesial, from the buccolingual aspect. And there's my signature. As you can see, not as nice as Neil Patel's and Scott Gann's. And so now we're doing our rotational movement using the towel forceps. You can see they really grab nicely with those serrations. And just slight elevation with the other one, and then just go right through using our LVtome in that case. Then debriding that site, this is a little bit of a bigger curette, and we've actually come out with these new rongeurs as well to just remove that apical area quite nicely. Again, cleaning up that area, that affected area, scooping it, and then I'm irrigating here with some chlorhexidine. So I like to use chlorhexidine to help clean out afterwards, and you can see there was an implant placed here. But these serrated curettes really work wonders, coming in different sizes to reach all different areas. I like to use this irrigation. I learned this trick from Scott Gann's about 3 or 4 years ago, and I haven't looked back. The effect on chlorhexidine for dry socket is not an issue. It actually is beneficial. I don't like to do it post-operatively, but I do like to do it intraoperatively. Post-operatively, I'm a big fan of just plain salt water, but even in these studies, you can see the efficacy of and efficiency of chlorhexidine has been quite beneficial. So that's what we do. Now we go ahead after we place our implant and pack in some bone grafting material. And we want to pack it pretty firmly. Some people say, oh, don't pack too tight, but I'm a fan of packing fairly tight. I don't want to squeeze it like an amalgam, but I do want to pack tight enough that I'm not going to have any loose particles If you think about what happens with vascularity, we have 0.25 is the smallest particle size. Blood vessels way smaller than 0.25 millimeters. So they're well below a micrometer. So I'm not really worried about blood vascularity. Just don't pack too densely where it becomes like a cement. And actually, did I skip something here? No, I didn't. Okay. And then we're just going to go ahead and suture. And now suturing has always been a problem for me. Been using Castros forever, and this is what I'm always happening to me. They're getting stuck in these areas, and I just couldn't take it anymore, where they keep getting stuck, and I have to literally pull out from that little area where that needle holder where it breaks, and pull it out to just try to tie off my simple knot. Obviously, I should have had to turn the other way. I realized that, but I don't want to think which way I'm turning. I just wanted to just slide right through. So I put it to TBS, the task, to actually make these a little bit better, and they did. They made it where now these can be hermetically sealed. So what do I mean by that? Well, let's take a look at the video. You can see here, again, nice Castro spring. I love springs, so like Castros instead of standard needle holders, the hemostat style. I like these Castro style. Here I'm doing just a simple figure 8 suture, and in that same case where we did use that PRF, I like to do it and add it to another one on the buckle, so I have like more like a figure 10 than a figure 8. And then as I'm tying, you can notice how it just slides right off. It's such a pleasure. I just wish somebody invented that so many years ago, where it just slides off and it doesn't get stuck in that little hinge. That drives me crazy all the time. No more am I being driven crazy from sutures. Very simply just breaks through that little notch there quite easily. And then we also developed these scissors as well to make it a little bit easier. I'm adding just another suture just to show you again how easy this is, how this just slides so nicely. So retract the tongue a little bit. Good retraction is important. And then again, just tying it off, and I'm going to go back through one more time and tying it off very nicely and having this nice seal. So someone's asking again, where do I get these instruments from? It's IDS is the name of the company. TBS is the name of the company. Integrative Dental Systems website, idsimplants.com. You can check it out, and you can find these as well as many others. And you can get just such nice, easy suturing, nice spring forceps, nice alveotomes, curettes, all these things from there. The only other thing was from Meisinger, that little burr that I used to debride it. So what happens when we extract the tooth? Well, first when we extract it and we don't do a bone graft, we're going to have some aesthetic problem because we're going to get resorption of that buccal wall. If that buccal wall is not super thick, and if you go back to some of my earlier lectures where we discussed this a lot, we end up with a buccal concavity, and we end up having to place the implant to lingual or having to do GBR at a second surgery. So the question is whether or not to graft or not to graft. Shakespeare wasn't talking about to be or not to be. He was asking to graft or not to graft. Well, yeah, graft. Graft for sure. Why? Look at this study from Bobby Horowitz and Dan Coleslow and Paul Rosen. They did a great study on this, and they found that you can lose as much as 3 to 6 millimeters of width when you don't graft. So unless you have a super thick buccal plate, like 2 millimeter buccal plate, it's going to want to resorb. There's no vascularity coming to it, and it's going to want to be compressed, and it's going to end up falling apart. So you can lose even height as well in a lot of cases in just 3 to 6 months after extraction. So instead of having a nice square ridge like this, by having a nice preservation, we end up having a really more pointy ridge, which is not to our benefit. Arroyo did a study on beagle dogs. I don't work with beagle dogs. I don't know about you, but I work on human beings. But beagle dogs do have accelerated healing. And look what happened in the study with Arroyo. Look at this drop from the buccal to the lingual plate. It's a tremendous drop, just 2.5 millimeters of bone loss in just 4 weeks. So it does show again that same philosophy. So what happens when we extract a tooth? When we take out a tooth, you can see from this animation, we'll go into a cross section here. Thank you to Geislich for this video. This alveolus will then fill with blood, and this blood clot is not enough. If this wall is very thin like this, it's going to resorb. If it's really thick like this, we'll be fine. But most buccal plates are not like that. Most palatal lingual plates are. So instead of having a nice ridge, it ends up shrinking into this type of a configuration. And then if we want to go ahead and put an implant, let's say 3-4 months later, it's often not enough bone for us to be able to place an implant in there. So whether or not we want to place an implant, or even if we want to do a bridge, if we're looking to do a fixed prosthetic bridge, 3 in a bridge. We'd like to preserve that bone so we don't have this aesthetic disaster like that. If we want to put an implant, again, we want to have that buccal plate intact. So what do we use for grafts? Well, I like autogenous. It's the best. There's no doubt about it. But I'm not going to go start, plucking out pieces of bone for the ramus just to do a socket preservation. So often we'll use things like allograft, like cadaveric bone. Synthetic bone does work well. I like to use it for a lot of different variations, like Nova bone in the sinus. You may have seen some of my videos on that. But I don't really love it for preservation. Xenograft cows, I like to eat them. They're delicious. I try not to use them in my patient's mouth, especially when my patients start moving. Nothing wrong with xenograft if you like it. It just takes too long for me to turn over. I like things that turn over a little bit faster. There is a use for them. I shouldn't say I never use it. I use it sparingly in my practice, really very rarely, mostly as a scaffold. So let's talk about this case here. So we can see this tooth is not in such good shape. So I'm going to have to extract it as well as back here in this tooth. And you can take a look and see just what kind of a defect is there once it was extracted. It's a pretty bad defect. It was actually about an 8 mm defect from the neighboring tooth. But we took out this tooth, and instead of just saying, let's throw this tooth in the garbage, again, we took our dentin grinder. We ground up that tooth, cleaned it off, put it in the grinder, and we did harvest a little bit of autogenous bone from the posterior area because it was such a large defect. So now in this area we have a mixture of dentin graft material and autogenous graft material. And you can see just how nicely that heals. So instead of having that 8 mm defect, that now all filled in with nice, good, healthy bone and plenty of bone for me to be able to place an implant. And we actually placed 2 implants in this case and developed some nice soft tissue. It's one of the things I love about the dentin grinder is that the graft material heals beautifully. And then patient came back in, this tooth was killing him. This is a few years later, and you can see the stability of that dentin graft material really holds very, very nicely around where our implants are. So what is PRF? Well, PRF is platelet-rich fibrin. It's using a concentrated technique where we separate the red blood cells from the white cells. We want to keep these leukocytes, keep these platelets. So what happens when we have an injury, when we have a cut? Typically we'll have a bleeding pathway and we'll need to stop that bleeding. So we may apply some pressure, but what's going on internally by these areas that have been cut and severed? Platelets are coming and creating a fibrin network. And this is what we like to use with our graft material to get this fibrin type of a clot. So we want to try to avoid things like anticoagulants in making our types of biologics. So if we have a fibrin clot and we can extract those growth factors that are released from the platelets and leukocytes that help stimulate the new cell formations and finalize our wound healing without adding an anticoagulant, that would be what's best for us. So originally in 1998, Richard Marks in Florida came out with this PRP formula, which was wonderful, but it required drawing blood using an anticoagulant tube. And Nitiwal came out a year later with this PRGF, and again required an bovine anticoagulant. So Shukruan came up with a newer technique in 2001, and since then have been employed several times over, using different techniques, and we have this blood draw without any anticoagulant. And that's just really a wonderful thing not to have to add any bovine thrombin into our sites. So we have this PRF material that we're going to extract from the venous system. So we'll go with a butterfly needle into the antecubital fossa or the hand or the wrist. You can really go anywhere you like. That's within the scope of dentistry. And go ahead and spin it in a centrifuge. And this is the part that we're going to keep. We're going to separate these red cells from these white cells. And then we can take this white cells and then we can use it to our advantage. So someone's asking about concern about violent bacteria present in the root when I grind it up, and how do I disinfect the root? Guys, the sodium hydroxide kills all within actually 3 minutes. So take 5 minutes of the sodium hydroxide and you're doing even extra good work. So sodium hydroxide, many studies on it. Don't worry about infected teeth. Just don't treat root canal teeth with the dentin graft material. Getting back to the PRF, we're separating the white cells from the red cells. We're going to create this little membrane here that we can then use to our advantage. And this membrane can last for 10 to 15 days. So it's not a membrane long-term like a cross-linked collagen membrane. This is similar to what we would call like a collagen tape, but it's going to be a lot better at stopping bleeding. So it's wonderful for things like third molar extractions. Barely ever get any dry sockets anymore using PRF because we're establishing the blood clot for the patient. We're not relying on the patient to establish the clot on their own. So let's take a case like this, where we have this tooth which has been fractured. So you see we take out the tooth and you can see this little fracture in the area here. We use the same principles of extraction that we showed before. And we've cleaned off the tooth. We're going to take this tooth, we're going to take a burr, clean out all this decay, get rid of a lot of the enamel, clean off all this tissue, scrape it off. It takes only about a minute in our hands. Now, it may take me a half an hour to do a DO on a tooth number 50, a second molar, but it only takes me like a minute to clean off an entire tooth. So very, very easy and quick to clean it off when it's sitting in your hand. It's just a pleasure to be able to do that. Put it in the dentin graft grinder. We'll get some nice graft material, put it in the sodium hydroxide to disinfect that area for 5 minutes. That's a new protocol, it's 5 minutes. We even have an ultrasonic bath now that we're using, which can even speed up even more, but just stick to 5 minutes until the rest studies are done. But take a look at what happens here. We take this material, and here I didn't add any PRF to this. I actually just, and it's actually congeals on its own in that sodium hydroxide. It's really nice for that. Pack it in very nicely, and just look how the patient comes back. We put the PRF on top of that, in this case, as a membrane. So we have the dentin and the blood. So we're keeping this completely autogenous. I call it CATS, completely autogenous solution. Tooth solution, you can see the 2-week ultrasound. Take a look at it. You can barely see the chromic gut that was used here, and tissue just grows really beautifully around these areas. So the combination of that is really wonderful. So let's put it all together. Everything we've spoken about tonight, using the instruments that we've done. So we'll start here with a full mouth extraction case, or full upper arch. And I don't have enough time to show you the whole mouth, but start with the top. So we go in and we can clean out, separate with the periotome. There is no other name for sodium hydroxide. It is sodium hydroxide, NaOH, sodium hydroxide. So you go in with the peritome and you get in between. You can see as we're using this peritome, you see how the other teeth are starting to wiggle a little bit because we're getting some movement. So in this case, I didn't have to go with elevators. I can just go straight with our Frings forceps and just simply remove them, extract them very easily by doing some rotational force. Even the canine is pretty nice there, coming out, some rotational movement, and try to move. And you can see these are pretty nice conical roots, so we don't have to worry about them breaking. If they have angled roots, obviously we'll want to elevate towards that, but just some slight rotational movement. And again, we'll get that last premolar, the last molar, I should say. Oh, that's premolar. That's the little root tip by the molar, and you can see we've got some nice extraction. And you go in with the curettes and clean it all out. Again, these micro curettes work wonderful with TBS. We get the sodium hydroxide from the same company who makes the dentin grinder. The dentin grinder is from Cometa Bio. Here is the surgical guide that we're going to use in this case to do an FP1 type restoration. So you can see here I'm using an R2 gate system from Medgen here. These guided surgery drills. We can do a whole another lecture on this another time. Hopefully I'll be invited back again for one of these. And we can do guided implant placement, having a stopper. You can see where it marks up. We've changed this up dramatically since we've done these surgeries. We now have windows, no more sleeves and things like that. Be another topic on R2 gate. But you can see we're lining up the implant line and to these black little lines to get our implants in the proper position. And we'll place the implants on top and install some multi-unit abutments. They're temporary cylinders on top of them. So we can actually deliver a same-day restoration. We've switched over to this guided smile type of solution from Row Dental Labs. You can check that out. But this is how I used to do it. It worked quite nicely. I want to show you something long-term. And then float some material in to cure it, removed it, clean off some of the acrylic holes there. We've changed this again a lot since we've done this. Remove this device, put the temporary prosthesis, and now we got to do some grafting. Again, we've ground up all these teeth, we've cleaned them off, we soaked them in sodium hydroxide for the 5 minutes, and now we can, from Cometa Bio, the dentin grinder, And we can pack this in place very nicely and just add PRF directly on top of this. I've already placed my implant, so no need for a collagen barrier. Simply just put the PRF simply on top of that and then do our suturing. Now, unfortunately, I didn't have my brand new Castros for this, so I did end up patching myself a little bit on some of these, but you can see we'll suture everything up really nicely, nice and tight there, but not pulling too hard. We want tension-free closure, not too much tension on our flaps, on our suturing. We'll put a bunch of sutures in, and it'll put about, I don't know how many for this case. Sometimes I'll employ silk in some of these cases to help stop bleeding. It works pretty nicely for us there. And then this is the healing that we can expect to see. And you can see just how nice the soft tissue is healed. And this is predominantly, I believe, due to the dentin graft material. Predominantly due to the fact that I've used a nice instrumentation to separate the PDLs very nicely and preserve the buccal bone that was there. Good implant placement using a surgical guide to help put me into the right position. I've covered everything with the dentin ground bone, which is wonderful at healing, and I really see wonderful responses to the bone and tissue from there, and then the PRF to help good coagulation process. And this is just about 3 months after surgery when we're making the finals. 2 months after surgery we make the finals, and it came out really nice. You can see here just how nice and pink and the soft tissue looks. We're able to deliver an FP1 prosthesis on this, on these multi-unit abutments. That's a whole other topic as well. So what do we do in terms of prescriptions for these patients? Well, antibiotics, I like to use Augmentin or amoxicillin, either one, 500 milligrams. You can do for 7 to 10 days. If they're allergic to Augmentin, I go to clindamycin. I'm not a fan of sulfa drugs, but clindamycin is one that I'll use, so no cephalosporins for me. Pain meds, I like to use NSAIDs. Acetaminophen works very nice. Ibuprofen, naproxen, all the different NSAIDs work. And narcotics, if needed, I really try not to give out narcotics, especially in today's day and age where opioids are just going crazy. We don't use any aspirin because of the bleeding content. And there is a drug called Exparil, which you can inject. It's expensive, but it works really nice. So if you have a big case like the one I just showed you, the Exparil, which equates to about $90 an injection, which you can use per one patient, lasts up to 72 hours of good analgesia. If you have a patient that you can do a lot of extractions and grafting on, steroids are a big plus, as long as they're not diabetic. I'll use a Medrol dose pack to help reduce the amount of swelling to that patient. Patient's a lot happier, and you'll be a lot happier when they're not all blown up when they walk in. So the post-op care, I know I'm rushing through this, so feel free at the end, take my email, I'll send you a PDF copy of this. The post-op care, bleeding, it can trickle up to 12 hours. If you're using PRF, I don't expect to see any bleeding. Avoid doing any real heavy motions, heavy movements, to not overstress the body to make blood rush to the head. Smoking is a big no-no, has to be stopped if we can, for as long as we can. We're obviously never really sure if a patient's going to stop. Usually my patients will tell me they'll stop for 12 hours, and then they'll go outside waiting for their taxi or their Uber, and they'll go light up a cigarette right in front of the office. So patients are just incredible that way sometimes. Swelling, well, I try to ice down as much as possible. I like to use these cool jaw straps. You can check them out online, called COOL jaw. And they wrap around from the chin to the apex of the skull, and you can slip some ice packs in on the side of them very nicely. Cleansing the morning after, not that day, same day. We'll start rinsing with salt water. We'll do that 4 to 5 times a day for 3 to 4 days. And make sure not to use, not to smoke, spit, or drink through a straw or any type of sport bottles, which will cause negative pressure and pull things out. And a cold, soft diet is very, very important. So I always like to leave off with a little bit of levity. Don't throw away those teeth. Use those ground up teeth. Extract them nicely using some good instruments like you saw tonight, and grind up those teeth whenever possible, as long as they're not root canal teeth. This is what we used to do, is sweep up teeth. So if you have a Taekwondo school upstairs, they can knock the teeth out for you, and then you can sweep up the floor with the teeth. This is always a funny video to me. So when a woman's turning 102 and see just the amazement of what happens when you have your teeth falling out there. This just happened the other night, which is kind of cool.
Right here,
was playing basketball and got elbowed
the accident elbow there from
Whoa,
Patrick.
there it is.
Patrick, look at him. He's trying to lift him up.
You can have my number anytime you'd like, Brooklyn. And we're going to lose our job one day to birds, it looks like. Looks like we may have some other dealings to deal with. Sometimes we can have some creativity of some kids doing some really neat things with that too.
Oh my God!
And I'd like to invite you to the Meisinger High Altitude Conference, which will be January 30th to February 2nd. Hopefully you guys can make it there. We're doing a hands-on workshop, myself and Dr. Scott Gans. And I'd also invite you to check out AIEdental.com to see some of our courses and videos that and techniques that we can do there. That's www.AIEdental.com. Lastly, I'll show you this little video about our course. This is our area in Tijuana, which you can see. I understand that it's possible that the video may have stopped. If that's the case, then I apologize. So, we're back on with the video. Thank you. So you can see some of the procedures we can do. We use the dentin graft material. We use all the forceps that you saw, the LV tomes and everything that we use there. We really do everything in there. So come join us in Tijuana, in Mexico, and come and practice a lot of these techniques. And again, you can see that at www.AIEdental.com. So I want to thank you for your attention. That's my email address, iketawil@mac.com. Be happy to send you a PDF copy of this presentation so you can further enhance your skills. I'd like to thank again TBS for making such wonderful instruments for us to be able to use in these videos, and IDS Integrated Dental Systems, who is a distributor of TBS instruments. And again, thank you all for coming and taking some time out from your days and coming to watch a video this late at night, and on some of the areas it's probably morning here for you, but I still want to thank you very much for waking up early. So thank you all again. I see some real nice friends here. Sadaf, very nice to see you again. Thank you guys very much, Intel and everybody, for your kind comments. If there's any questions, we have a couple of minutes left. I'd be happy to answer them for some Q&A. Looks like I think we're done with questions. So thank you all again very much. Have a wonderful evening. You're welcome, guys. Thanks a lot. Wait, we do have a question. Okay. Marshall, you're a very funny guy. Very much. Thanks, guys. Thanks, Dennis. Marshall, you're a real pisser. I have to meet you, Marshall, real soon. Amit, thanks for watching. Thank you, Darren. Oh, Darren, how are you, man? Good to hear from you. A lot of good friends that stayed up late for this. Appreciate this very much. Any other questions, guys? You're welcome, Melissa. Thank you for listening in. What happens if you don't take out granulation tissue? Good question. With 2 minutes left on the clock. So if you have a granulation tissue and you leave it and you pack bone on top of it, then there's a good chance that you'll end up with a hole in there that will stay in there for good. And if you're going to go place an implant back in there, that's not always the best situation. So clean them out as best as you can. If you left the tiniest little dot by accident and you didn't see it, I'm not so concerned. It loses its connection to the oral cavity, so I wouldn't worry too much. But if you leave a big piece of granulation tissue, that is definitely a problem. So please feel free to send some more emails, questions to my email if I didn't explain it well enough. Thank you guys very much. Hey, Matt Chang, Novielli, I love when you chime in. And it's great to hear from you, man. I hope to see you soon. All right, and thank you, Hasib, and thank you for making such great instruments. I'm glad you watched tonight. All right, guys, looks like that's all the time we have. Thanks again a lot, guys. Have a wonderful evening, and I hope to see you at the next Viva webinar. All the best to you all, and a happy holiday season to all.